Our first speaker in this second session will be Dr. Sonja Novak-Zezula. So she has a PhD in sociology, and she is managing director of the Center for Health and Migration. Her main fields of interest are health and migration, with a special focus on vulnerable migrant groups and quality development of health services and public health systems. Dr. Novak, please.
Thank you for the introduction here. Welcome, everybody. Thank you, the organizing committee of this conference from ALIA and FIAM, for inviting me to speak about migrant health and the economic aspects. Well, my presentation was perfectly summed up by Elisabeth in her comment the last session, when she said that there is a body of evidence that shows that including migrants into primary health care, preventive services is cost saving. In my presentation, I will give a short overview on ethical commitments and economic consideration regarding access to health care for vulnerable migrants. I'm referring to vulnerable migrants especially. We have heard that there is a broad range of characteristics migrants have, that there are many different types of migrants. We are talking about diplomats as well as about their housemates, so in a very privileged situation and in a very underprivileged situation, perhaps living in the same building. I will talk about evidence that's available on costs of care for migrants, and I will give you some deeper information on a study we did on healthcare provision for migrants and ethnic minorities, where a cost analysis has been done. The right to health care is acknowledged in many international declarations. However, often it remains unclear who is really included in this right to health care. There is no defined statement on population groups, and it's not specified which kind of services should be offered to which migrant groups. Here we can see the WHO constitution that says that the highest attainable standard of health is a fundamental right for every human being. The Sustainable Development Goals from 2015 define the achievement to achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccinations for all. The European Union Charter of Fundamental Rights defines that everyone has the right to access to preventive health care and the right to benefit from medical treatment under the conditions established by national laws and practices. These national laws and practices differ among the European states, and what we can see here is a product from a project we did in the early 2010s. It was about healthcare access of undocumented migrants in the European Union, Switzerland and Norway. And we analyzed regulations and entitlements for undocumented migrants. And these three colors, red, yellow and green, stand for the openness or restrictedness of systems. Those countries that are given here in green are those who provide services for undocumented migrants on the same level as for nationals. Then we have the big range of red marked countries, those are providing emergency care only. And then there are some countries that have more than emergency care provision under special conditions or somehow restricted. As we heard in the first session today, there are not only legal restrictions to access healthcare systems for migrants, but also practical or administrative barriers. I just listed few: the ability to follow administrative procedures, the lack of knowledge on how to navigate the system, language and cultural barriers, fear of being discriminated against, mistrust are factors that impact accessibility. Although we see here a map that focuses on undocumented migrants, we can see that this accessibility barriers also are impacting health of migrants in a legal situation. Economic considerations have to answer the questions: can society afford health care for all? This is the first question, and the second is: what are the costs and the benefits from ensuring or restricting entitlements and access for different groups of migrants? The resolution of the Council of Europe on equal access to healthcare says that inequalities in access to care, including mental health care, particularly affect vulnerable groups, especially those in an irregular situation. These inequalities lead to a phenomenon on recourse or delayed resource to care, which could have disastrous implications for both individual and public health and lead in the long term to an increase in health expenditure. There are a few recent studies that have dealt with this phenomenon. I have listed 3 of them on the right side. One was done by the European Agency for Fundamental Rights, who had a cost model for 2 specific health problems in case of prenatal care on the one hand and hypertension on the other hand, and they calculated costs in 3 countries, for Germany, Greece and Sweden. What is shown here is that non-treatment or restriction in treatment are getting more and more expensive in the system as it comes to health problems that have to be treated later on. A German study worked with data from asylum seekers over 20 years, and they did a quasi-experimental study which showed that restrictions incur higher costs. And the last study is one that we did on our Center for Health and Migration. It's a study on cost saving through timely treatment for irregular migrants and EU citizens without insurance. It was commissioned by IOM Regional Office Brussels in the framework of the EquiHealth project that was listed in the morning session. All these studies have used different methodology, have worked with different data sources, but however they have similar conclusions, and this conclusion is that it is not cost saving to restrict access to healthcare to emergency care only. I will now give you some more information on this study we have conducted. It was an analysis and a comparison of costs of healthcare provision in 4 European countries. It was Austria, Belgium, Spain and Italy. We focused on migrants in an irregular situation, including Roma and including EU citizens without insurance. We have this quite paradox situation that even as a EU citizen you can get in an irregular situation in another EU country after quite a time, and the situation gets more and more difficult. What we did is we compared the cost of primary care, that scenario we called timely treatment, and hospital care, delayed treatment, for primary care sensitive conditions. We used a methodology that was based on the collection of primary data. Then we constructed vignettes. Vignettes are scenarios with different elements that can be varied so that you can calculate for different outcomes. We used vignettes for the primary care and the hospital setting. As I said, the study was conducted in the EquiHealth program, commissioned by the IOM Brussels, conducted at our Center for Health and Migration, and we had an advisory committee. In all of the 4 countries, we had some implementation partners who helped us to access services that provide healthcare for irregular migrants. Médecins du Monde Belgium is one of these organizations. And then we had practice partners, organizations that provided us with data, who conducted interviews with their patients, and who were very helpful when it comes to tell us about the situation of undocumented migrants and specificities in care. The data we collected included the health problems and all the treatment processes as diagnosis, therapy, and facilitating services, especially cultural mediation and translation services that were necessary to communicate with patients. And we also collected the related costs. To get more information on the situation of patients, we also collected data on wider determinants in health, on living conditions, work, income. And we also asked people if they are responsible, financially responsible for relatives or friends, either in the country of stay or in their country of origin. So to see how many people have to live from the income a migrant earns. We had a selection of diagnoses we used for different vignettes. You can see them listed here: asthma, coronary heart disease, depression, diabetes, epilepsy, and I should have put it in the brackets, tuberculosis. I'll tell you afterwards why this is so. We were using a microcosting approach. That means that we created vignettes based on this primary care data and then calculated related costs on 3 levels. We were calculating costs that occur for the patient, for the healthcare system, and for the society as a whole. Costs were collected on 3 levels. Direct medical costs, that means medication, treatment costs, the time of the health professional. We calculated direct non-medical costs that occur when time of a patient or travel costs are taken into account, and indirect costs that are especially important for society when it comes to loss of income and productivity. This, from my perspective, is the most difficult type of cost because we are here talking about people who are not working in the regular labor market. However, the productivity they have is counted into the GDPs of countries, so there is a kind of difficult situation in this regard. When we had these vignettes, you can see we have, for example, here in Belgium, a male patient. He comes from Guinea. He is 25 years old. He works in Belgium by teaching extra math lessons on the black labor market. He lives as a squatter. He addressed MDM, giving symptoms that show that he has epilepsy, he's also diagnosed, and he is treated in the primary care setting. So this was the real life case we collected. In the vignette, we made his diagnosis, his health problems a bit more severe. So there was a minor epileptic seizure he was suffering, and this was the reason why in this vignette approach he was referred to hospital. And then all the calculations started. We used register data, the Eurostat database, national fee catalogs, and so on, to make this microcosting for all the different scenarios. When it comes to the outcome for all these diagnoses, we see that there is a potential cost saving of timely treatment in primary care that are about 50 to nearly 100%. These are rounding errors. They occur in hospital setting for treatment of more severe medical conditions. What makes this 100%, because that's always a big question, is one case that comes from Spain, where we collected the primary data in a hospital, and it was a man with a coronary heart disease who had all the medical program he could get. He had a surgery, he got bypasses, and so on and so on. So having treated him in an early stage of his disease would have saved a lot of costs. What we saw in this study was also special vulnerability of a Roma population and other citizens from poor EU countries. We have learned in the former session that we have a big discrepancy between the rich and the poor European countries, and this also gets visible when we see internal EU migrants in this health regard. What also gets very, very visible is again the interrelation between irregular migration and the black labor market. So there are people profiting from irregular migration in economic terms in Europe, and those people are not the irregular migrants, you can say. This is a product we have developed as a kind of infographic that shows 4 examples of vignettes from the different countries and shows how the amount of money that could be spent if early treatment in primary care is given. I've brought some copies with me in case you're interested. Please just let me know. Yeah, and when it comes to the recommendations, we strongly agree with the speakers from the first session. What is important is to have migrants and especially vulnerable migrant groups on the agenda of public health, to apply public health instruments of planning, implementing, also monitoring. We have a big lack of data in this field, and evaluation accordingly. We also agree that access to preventive and basic health care should be accessible for everybody, irrespective of the legal status. We somehow are not so convinced from economic studies that it makes sense to give specialized care to everybody, because you have to follow case-to-case decisions. It is important, if you have a patient who gets hospital treatment, that you can provide a setting that allows him to get well and better and live better after hospital discharge. So it does not make sense to have the whole program and stop there and send people back to living conditions that make them ill. So you need accompany this medical treatment by social support. What would be necessary is more transparency and empowerment of all actors in the field, including the general public. What we can see is that healthcare for undocumented migrants is mainly provided by NGOs who have to manage this paradox situation, to have the general regulations of fundamental rights on the one hand and restrictions on national level on the other hand. So this paradox situation has to be managed somehow, and this is done mainly by NGOs. And give them the possibility to have to act transparent and to make visible what they do and what efforts they take and how much volunteer work is included in all this healthcare for irregular migrants is of utmost importance. Summing up, if we talk about human rights, economic arguments do not make any sense. Human dignity cannot be argued in economic terms. So this is not the case I'd discuss on an economic basis. But if we talk about public health, then economic arguments are part of the discourse. And it's not about do we give treatment or not, because here we have to rely on the human rights. But it's about which treatment is most effective and efficient for most people who are in need of it. So it's the question is on which services are provided, in which quality, and who should be included. And this is a discussion that is not finished by now, and I think this will be of utmost importance to give the right frame for working in this field. There are a number of questions we would love to work on in this regard. There are some organizations that informed us that they're dealing with multimorbidity, and this is increasing. So it would be also interesting to have economic models that cover this difficult medical situation. And what we can see and what we have learned is that many irregular migrants or vulnerable migrant groups suffer from non-communicable diseases, but however, specified models are needed when it comes to infectious diseases, for example. Yeah. Okay. Thank you very much for your attention. Looking forward to your questions.